Yeah, my name is Gopal Krishnapal.
Can you hear
Most
me?
welcome. Yeah, yes, I am hearing. Most
Can
welcome,
you hear
most
me?
welcome.
Yes, madam. Good afternoon, madam.
Good afternoon. How are you, Dr. Joshi?
That's fine, madam. I'm fine. I was listening you
Nice.
to talk with sir, and sir is really our director. Sir is really make us like he's very encouraging. Always he encourages us to organize the different type of events. So and
नहीं आप एक्सपर्ट डालते हैं आप देखो पहला रिस्पांस मैं देती हूँ डॉक्टर जोशी always whatever you put in X or Twitter handle so-called Twitter handle now I always reply to that sometimes there is nursing program sometimes
yes,
there is some program I was looking at all the initiatives it's so good and there was
Ma'am,
some
we are live now.
sure
Madhu.
Okay, shall we start, ma'am?
yeah
So, good afternoon, everyone. I am Dr. U. Venkatesh on behalf of Department of Community and Family Medicine, AIMS Gorakhpur. Welcome you all to this webinar titled Integrated Research, Policy and Innovation in Hypertension Management on the occasion of World Hypertension Day. Last year, on this day, AIMS Gorakhpur hosted an event at Indian Habitat Center focusing on strategies to achieve India's 75 by 25 initiative in collaboration with Ministry of Health and Family Welfare. This year, our webinar is dedicated to delving into implementation research, pinpointing gaps in existing hypertension programs, and examining the role of technology in improving hypertension management. This effort aims to bridge divide between research findings and clinical practice, ensuring the development of effective strategy for enhanced health outcomes. Today, we are delighted by the presence of our esteemed guests and speakers. I would like to welcome our head of the department, Dr. Harishankar Joshi, sir, to deliver the welcome address.
thank you, Dr. Venkatesh. And it's a really a great pleasure. And first of all, good afternoon to all of you. It's a really a great honor and pleasure to welcome you all in this webinar titled Integrating Research Policy and Innovation in Hypertension. So, this is more important because we are organizing this thing on World Hypertension Day. First of all, I extend my warm welcome to our respected Executive Director, Sir Dr. Gopal Krishnan Pal. His visionary leadership and encouragement to us motivate us to organize different type of events in AIMS Gorakhpur. And after he joined, the AIMS Gorakhpur is continuously achieving milestone. Thank you, sir, for giving us your precious time. I know that you are very much busy because you are holding charge of two AIMS. You are leading two AIMS like AIMS Patna and AIMS Gorakhpur. So thank you, sir, for your precious time. I also welcome Dr. Sunila Garg, madam. Dr. Sunila Garg, madam, is a name in field of public health. She need no introduction because she motivate her presence, her activities motivates us to do something special in the field of public health. I also welcome our esteemed speakers, Dr. In which first is Dr. Asu Grover, madam. She is a scientist F and head implementation research in ICMR Delhi. And madam, you are also increasing encouragement for all of us. Dr. Jugal Kishore sir, who is a director professor at Vardhan Mahavir Medical College. Dr. Ravinder Singh, who is a senior scientist in ICMR. Dr. Pradeep Agarwal. So on behalf of organizing committee, I welcome you all in this webinar, and I also welcome to all the participants and delegates from different part of the India, and I welcome them, and I hope that this webinar is very much useful for you all, and it is helpful to you all. Thank you, Dr.
Thank you, sir. Thank you so much, sir. Now I would like to introduce our guest of honor, Dr. Sunla Garg ma'am. Ma'am, with 43 years of professional experience, she has made significant contribution to public health and health system strengthening. She is professor of excellence and chair the program advisory committee at National Institute of Health and Family Welfare, and notably She has been recognized among the top 2% of scientists globally by Elsewhere in 2022. Over to you, ma'am, for your address.
Madam, you are mute. Madam, you are mute. Madam, please unmute yourself.
Yeah. Thank you, Dr. Joshi and Dr. Venkatesh. It's always a pleasure, to be addressing AIMS Gorakhpur, and especially this is a special day when, we have new director, Dr. G.K. Paul. And I know that how enthusiastic he is, and with this regular, tweets on the X handle, I always, admire him with that kind of this thing, vision. And I know that the year has passed by very fast. When last year we had observed 75 by 25 initiative. And we have with us our colleagues, Dr. Ashu, Dr. Jugal, Dr. Ravinder. All, they bring, wealth of experience from different parts from ICMR and all that. And plus, my very own Dr. Pradeep Agarwal, I know that how active he has been playing a very important role with Dr. Om with from Global Health Advocacy Incubator. We know that, particularly with my very two own students doing their research on diabetes and hypertension. One was done amongst adolescents, and this I'm talking is about 6 years back. And then the second followed by that was done in adults. And we had, the range of hypertension varying from 13% to around 19%. So I'm talking of, young youth, which are, I'll say the future of the society. And this is where we have to play an important and critical role as well. And overall, when we look at, 1 billion hypertensives across the world, we cannot sit like that. And particularly when looking at all of these things, we launched India Hypertensive Initiative as well, which also brought a huge prevalence of hypertension. But apart from this, it only showed, that there is a big chunk of population where the hypertension, it was about 50% of the hypertension was not even controlled hypertension. So that's where we need to look from that angle. And also there is a huge role of, research, policy, and innovation, particularly when we talk of today, in the era of smartphones, in the era of cuffless devices, in the era of, M technology, it's not only important to diagnose, but it is very, very important to, kind of manage it properly, and people should adhere to the treatment. And now we are talking of reversal of non-communicable diseases, and Dr. Ashu will agree with me that the very few, I think months back, we started with integrating of non-communicable diseases with mental health, because this overall we have to not look only at hypertension alone, but we have to look overall as, as a human being, and particularly we need to move from the concept of health to wellness as well. So this was one of the kinds of implementation research, integrating NCDs and mental health together, and of which, hypertension was also an integral part. So that is where, our Dr. Ashu will bring a wealth of experience in terms of implementation research as well. So, but we all have to be aware of the fact that particularly post-COVID, and today only I got a call from, BHU about the study which has been released by Covaxin and all that, Covaxin group about Covaxin, and few days back, we also had information about Covishield vaccine. So about talking about the side effects and all that, but what we need to remember is that the vaccine was an emergency use vaccine, but important part is that we cannot forget that people who suffered from non-communicable diseases, particularly diabetes and hypertension, were much more prone for these diseases. So all the more it is important to focus on hypertension management, and at least by 2025, we should be able to bring down 25% of the cases. And it is not a question of reaching to the metros, but, reaching to the last mile. That is when we call as Arogya Mandir, we must reach over there, because NCDs is one of the 12 task forces which is being implemented, at the health and wellness centers, and our Ashas, Anganwadi workers, and our CHOs are much more informed also. And also, I will say that here AIMS Gorakhpur also has got a very important role to play, because, we are trying for smart health and wellness centers. So I feel that AIMS Gorakhpur should do something different, and we need to talk to our own, a lot of faculty members and PGs and everyone who has joined. I'm sure they're going to benefit by, the term hypertension, its management, what are the newer innovations, and always focus on the research part that is important and know about what is the policy of Government of India. So with this remark, it will be my pleasure to listen to all the three speakers, and thank you, Dr. Joshi, for organizing this along with Dr. Venkatesh. And I'm sure that Dr. Pradeep is always very active, in these initiatives. So over to you. Thank you so much. Thank you.
Thank you, ma'am. Thank you
ma'am.
so
Thank you,
much.
ma'am. I
You
also
really set
welcome
the
to Dr.
background
Pradeep
for this
Agrawal, who is
webinar.
additional professor. I hope that he is online. Dr. Pradeep Agrawal also, I also welcome you for this webinar. Now, what do you, Venkatesh?
Yes, sir. Now I would like to welcome our chief guest, Professor Dr. Gopal Krishnapal, sir. Sir is director of AIMS Gorakhpur also and Patna also. And sir has a distinguished career over 3 decades in teaching and research. His works primarily focus on neurophysiology of disease such as hypertension and diabetes. Sir holds numerous fellowship and has received 25 national research awards. In addition to his academic and research achievements, Sir is also known for his leadership in various scientific societies and as the chief editor-in-chief of a prestigious physiology journal, underscoring his influence and commitment to advancing medical science. We are delighted by your presence, sir. Over to you.
Good afternoon, all of you. Namaskar. Greetings from AIMS Gorakhpur and AIMS Patna. Am I audible clearly?
Yes, sir. Yes.
Yeah.
Yes, you're audible.
All my esteemed colleagues, Professor Sunila Garg, Dr. Harishankar Joshi, the Dean Research, Dr. Asu Grover, Dr. Jugal Kishore, Dr. Rabinder Singh, Dr. Pradeep Agarwal, my colleague, Dr. Venkatesh, all the participants, and all my dear students and those who are listening to this webinar. It gives me really a great pleasure to know that the AIMS Gorakhpur is organizing such a beautiful program, the webinar on the topic integrating research, policy, and innovation in hypertension management. Indeed, the topic is very well designed because we need to have innovation in the patient management, the hypertension management. We have to have the research to go to the innovative research to go to the in-depth analysis of how the hypertension really occurs, and accordingly we develop the policy, and then we take a decision on how actually we go ahead from now onward. To my knowledge, what actually as a student in 80s, 1980s, I have seen actually how the hypertension management was happening and what hypertension management is happening now. There is a total paradigm shift because of the research innovations. I'll share my own experience and the data I have collected from the hypertension research. At JIPMER, after doing my MD, I joined there, and then after when I became senior, actually that time I did PhD, and when I became head of the department, actually I registered for PhD, and my topic for PhD was hypertension and yoga. I'll tell you this hypertension, as you know, actually this is a silent killer because often we do not know that we have hypertension because essentially the features of hypertension are very non-specific. Hypertension never comes with a specific feature. There will be some weakness, maybe headache. Sometimes you get some non-specific malaise and all. And there are many actually causes for those non-specific problems. Therefore, anybody complaining of these problems, we never think that the person may be having this high blood pressure. Therefore, most important actually for this hypertension management is the screening of the hypertension. So for that, the community screening, and especially those who are at risk, those who have the family history of hypertension, and the little aged, or even nowadays, even young people, those who are having stress, they should undergo regular screening for hypertension. Hypertension, actually, to my knowledge, this is one of the most prevalent disease. as per the information that I have, the 2020 National Family Health Survey speaks actually that 19% and 17% of males and female are having hypertension. Then 2023 report says it is close to 30%, which is just 1% less than the global 51% of hypertension. More alarming what actually we have done in our research and studies at JIPMER and also the papers published. More than hypertension, what is actually the silent killer is the pre-hypertension. Pre-hypertension is more prevalent. It is said actually pre-hypertension is close to even 33%, 35%, even in young people, the young adults, they have pre-hypertension. Even in we had a study in the school going children, they are having, many of them are having pre-hypertension. And there is another form of hypertension in pregnancy, that is gestational hypertension. Hypertension in pregnancy, that is also quite common in India, especially in the developing countries. It is 5 to 15%. So globally, hypertension is prevalent. India is one of the country where hypertension is quite prevalent. The common causes of hypertension in India, what we have seen, that it is because of, though the factors vary from region to region, but in general, the hypertension is mainly due to obesity, change of lifestyle. Earlier, actually, we had no money. Now, actually, the India is one of the richest country, and suddenly there is an economic growth. And this sudden rise in economy had made people not to do much. Actually, the physical activity is much less. Sedentary life has resulted in many problems. One is obesity. Obesity is one of the factor for hypertension. In fact, decrease in body weight, by 1 kg results in decrease in blood pressure by 2 millimeter of systolic blood pressure by 2 millimeter of mercury. Apart from obesity, another one in India, the salt intake. We are actually accustomed to take food rich in salt. So salt intake, the extra salt intake, more salt intake. In South, rasam and sambar cannot be taken without salt. And in North, actually, there's all the curries, the masala curry, the fish curry, all these, curries, there is no taste if there is no salt. So we have to really cut down the salt. Then apart from that, the internal stress, more than the physical and the work stress, the internal stress, this is one of the factor that contributes to hypertension. Though there are many other causes, so these are the few causes of hypertension, and also sleep. Duration of sleep, the type, quality of sleep, and when we are sleeping. These are some factors actually they contribute to hypertension. Why I'm telling actually, we always say, people, they send a message. I see the message has come. My cell phone remains on because heading the two institute, my cell phones are always on. Any problems, the people contact me even in the middle of the night in the hostel, students problem, hospital problem. People I see actually they send to me the message 2 a.m., 3 a.m. Good night, sir. But by then it is not night; it is already day. When we say good night, it should be really in the night. We should say good night. See, we go to bed much late and we get up late in the day actually, and that is one of the cause of. I'm just speaking physiologically. The cortisol secretion is totally disturbed. So cortisol, then all this, this adrenaline, noradrenaline, they really all contribute to this vasoconstriction. So these are the some causes. Actually, I just wanted to say how hypertension happens, because the topic is actually the research and the policy and the innovation. I'll speak few words about the research of hypertension. What actually we have seen physiologically, and also we know the basic concept that hypertension is due to finally the constriction of the blood vessel or increase in blood volume. Increase in blood volume is because of the salt causing the water retention, but that is may not be the most physiologically most prominent cause of hypertension. Pathophysiologically, what happens? The blood pressure, the blood vessel, they constrict in response to sympathetic overactivity. Sympathetic charge when increased, that causes vasoconstriction, increases blood pressure. But what we have seen actually in our studies, in addition to increased sympathetic discharge, there is decreased vagal activity, that is called vagal withdrawal. So along with the sympathetic discharge, there is decreased vagal withdrawal, that is called vagal inhibition, decreased vagal activity, that actually also contribute to hypertension. Decreased vagal withdrawal, the vagal activity, is not directly linked to vasoconstriction, but it has a lot of link with the heart function. Decreased vagal activity results in a lot of cardiac problems. Vagus nerve controls heart activity, sympathetic system controls the blood vessel activity. So when there is extra sympathetic activity and decreased vagal activity, both of them contribute to blood pressure and the complications associated with blood pressure. Hypertension people, they report, actually, why I'm telling this at AIMS Patna, often I get phone calls from many that they want actually the patient coming to emergency, with the intracerebral bleed, huge bleed, so much of hematoma. And when we take the history, we see that they are first time they are detected hypertensive, and they actually have come to AIMS Patna hospital with the intracerebral bleed. So people do not know that they had hypertension. For the first time, they have come with the history of with the complaint of this, the sudden loss of consciousness. Then when you do all these things, you see that there is intracerebral hemorrhage. What actually I'm telling you, these people, they are at high risk of sudden cardiac death unless they are attended immediately. We have seen actually they die in no time, actually, not just because of stroke, sudden cardiac death. And what we have seen, this cardiac problem, the cardiovascular risk associated with hypertension is not just due to the sympathetic activity, but due to the decreased vagal activity, that is called the vagal withdrawal. And physiologically, we say this is sympatho-vagal imbalance. So the imbalance between sympathetic and vagal activity contributing to cardiovascular risk, sudden cardiac death, and many more complications are the real concern. Why I'm telling you this decreased vagal activity, when we go to the hypertension management, the innovation from our work and the works published, which was also part of my PhD work, yoga is one of the, very affordable. It is actually, there is no cost, but then people have to be encouraged. Yoga is one of the best method of management of hypertension. Hypertension is one of the disease that can be fully controlled with nutrition management, with lifestyle management and yoga. People should be educated. People should be really taught. They should be actually given demonstration. They should be given all kind of awareness program to say that if they do yoga, they practice yoga, then this hypertension can be totally controlled. Unlike diabetes, once there is diabetes, with yoga, diabetes can be minimized, but actually you cannot cure diabetes fully with yoga. Hypertension is a disease. It can be totally controlled, especially this pranayama, this the slow breathing pranayama. That increases the vagal activity, that decreases sympathetic discharge, ensures vasorelaxation, and some of the pranayama, like Bhramari pranayama, increases release of nitric oxide, which is a known vasorelaxation factor. And yoga is very effective. Just to do yoga for half an hour in the morning, 15 minutes in the evening, the little bit of Surya Namaskar, basic asana, and some pranayama, and evening just pranayamas, the slow breathing pranayama. That will ensure that your blood vessels are maintained in a relaxation state and you don't have problem. So what actually I'm telling, that yoga should be part of the policy decision of the management of hypertension. In addition to other, what actually we have, the medicine that we prescribe. Medicine, the patients must take medicine in the acute stage when the blood pressure is controlled to a limit. Then they should be slowly shifted to yoga with medicine. Then slowly medicine can be withdrawn. Then just yoga, they can keep continuing. And yoga is not only for treatment, yoga for prevention of hypertension and heart disease. So just I wanted to say that increased vagal strength achieved by yoga should be part of the policy decision of the government, of the scientists, of the physician, that the hypertension management, this can be one of the innovation. I congratulate the Department of Family Medicine, Community and Family Medicine of AIMS Gorakhpur, Professor Joshi and Dr. Venkatesh for organizing such a beautiful program. And my sincere thanks to all the participants, especially my sincere thanks to Dr. Sunila Garg, Dr. Ashok Grover, Dr. Jugal Kishore, Dr. Ravinder Singh, Dr. Pradeep Agarwal, and the galaxy of topics that you have put up with such experts really speaks the quality of webinar that is being organized. I congratulate my faculty and the department, all the faculty for organizing such a beautiful program, and all my best wishes. Thank you all.
Thank you, sir. Thank you so much for your enlightening remarks.
Thank you, sir.
You have given us comprehensive review by sharing NFHS statistics, shedding light on pre-hypertension and community screening, and discussing the physiological aspects and reaching into the research. Thank you so much, sir, for enlightening us. And with your permission, we would like to begin with our technical session.
Please go ahead. Please go ahead. Thank you. Thank you. Please go ahead.
Thank you, sir. And with permission from chair, I request, I would like to begin the technical session as well, because Dr. Ashu Grover ma'am is also having some meeting at 3:20. So with permission from Sullagar ma'am, I'm welcoming Dr. Ashu Grover ma'am for her presentation. Ma'am, with she currently heads ICMR implementation research. Ma'am is scientist F, and she has pioneered significant initiative for health research across India with focus on epidemiology and health system strengthening. Ma'am has authored more than 100 research papers and played a crucial role in advancing health technology assessment. Her extensive experience and insights are instrumental in shaping public health policies and intervention at the national level. Over to you, ma'am.
A very good afternoon to everyone. First of all, my congratulations to the Executive Director, Dr. G.K. Pal, my mentor and teacher, Dr. Sunila Garg, my co-technical experts for this webinar, for organizing this session on a very important day when we are celebrating the World Hypertension Day. So, Dr. Venkatesh, are my slides visible?
Yes, ma'am, it is visible.
And they are moving?
Just
it is
move
not
them.
moving, ma'am.
Move them. It's not moving.
Now?
Yeah,
it is
now
fine, ma'am. It is moving.
Okay,
Please do it.
wonderful. So, we are celebrating this day, World Hypertension Day, and Dr. Garg, Dr. Pal, and Dr. Joshi have already highlighted the importance of this very significant condition, which is a very, very common public health problem. From not only Indian perspective, the entire globe is, struggling from this particular entity, which is not only itself a condition in itself complete, but it is a risk factor for many other conditions as well. Most of the neurological conditions, most of the endocrinological condition, many of the heart conditions, many of the other peripheral vascular diseases are the sometimes sequelae of the hypertension. But the theme for this today celebration is measure your blood pressure accurately, control it, live longer. So with this theme, if we analyze the theme very carefully, that they're asking every person, not only the patient, not only the community, not only the person himself, but to the health systems also, that every blood pressure has to be measured accurately. There is what we lack into it, and then control it. Control it, the blood pressure through the health system is a major challenge. And of course, when these two things are done, we are going to live longer. So I will be putting up my presentation, my talk for over 15 minutes or so, and dividing it into three parts. First part of my presentation would focus on the hypertension scenario in the country, and how are we going to, what are the different fulcrums, how we can control it, what are the Indian public healthcare system. And the second part of my presentation would be a live example with the India Hypertension Control Initiative, which ICMR has undertaken a study and has been successfully implemented across various states in the country and is in the expansion stage. And my third part of the presentation would be a little bit about how to carry out the implementation research, which is the need of the hour if we want to take the research into policy and research into action. So, as we have already listened from the experts earlier, that we have around 63% of all deaths in the country are attributable to non-communicable diseases, and cardiovascular disease contribute around 27% of the deaths, and hypertension, raised blood pressure, is a critical risk factor for the cardiovascular disease, and not only for cardiovascular diseases, for other neurological and endocrinological, peripheral vascular, and nephrological conditions as well. So this becomes our moral responsibility as the healthy citizens of this country and healthcare providers, pillars, researchers, and academicians of this country to make the system responsive to the person who are going to suffer either from hypertension or the risk factors from the hypertension. So if we have that 12% of the people with hypertension in India, if they have their condition under control, that will indicate that, okay, yes, we are going in probably the right direction. Dr. Pal has already talked about the NFHS data 5, and it has really shown that we have the systolic blood pressure in urban and rural around 24% of the population above the age group of 15 years is having among males elevated blood pressure, and so is not less than the females also. Above 140 systolic blood pressure is about 21% of the population is having that kind of data. The risk factors, there are various risk factors. It has been talked about that stress is a risk factor, dietary intake is a risk factor, obesity is a risk factor, but we can categorically divide these risk factors into three major categories. This could be the behavioral risk factors, the physiological risk factors, and leading to the different outcomes. Sometimes the disease conditions itself may lead to the raised blood pressure among individuals, and they can be coexisting also. So among behavioral risk factors, we have the tobacco consumption, again a big problem for our country. Alcohol use, unhealthy diet, packaged food, processed food, physical inactivity, air pollution, and all of these behavioral risk factors, if we start talking about all these factors independently, is going to take around 15 to 20 minutes each. But we all know that how do we have to control all these factors and what are the factors contributing to, for example, physical inactivity. We do not have sufficient workplace. We do not have the appropriate, parks to roam around. We don't have the behavioral intention to do the physical activity. Same is the air pollution. Again is the alcohol. Then physiological risk factors like overweight, the obesity, raised blood sugar, raised cholesterol, and disease outcomes. Like I said, some of the conditions, it can be co-associated with the comorbidity conditions also. So this is something about the public healthcare system, and our Indian public healthcare system has to be responsive. And if we want to make it responsive, it can really work out it. And at the lowest level of the healthcare providing system, we have the sub-centers to the catering to the population of around village 5,000 and so, and now we have the Ayushman Arogya Mandir, and many changes have been done over a period of a decade or so. We are enhancing the scope of the activities at the peripheral level of working, peripheral level institutions, again at the primary health center, again at the community health center and the district hospital. So what I'm trying to show over here is that this is not such a condition that need to be the problem of the district healthcare hospital or the super specialty hospital or to the medical college hospital. Containment or control or prevention of hypertension is a condition which can be easily curtailed at a primary or this sub-center level or the Ayushman or Arogya Mandir level as well. Just needs the blood pressure, just needs the availability of the drugs, just ensuring the behavioral practices among the providers and among the population also to get them make aware of that, okay, at least we should get our blood pressure examined in a very routine frequency interval. So if we want to achieve the 75 by 25 initiative, which I will talk in my subsequent slides, that each healthcare sub-center, which is now Arogya Mandir, caters to a population of 5,000, and we need to screen 1,850 individuals to be by 2025. And for that, we are able to get around 450 to 520 hypertensive patients and few of the diabetic patients, around 150 or so. So by that matter, if we are able to screen such a large population, even at a sub-center level, even at a lowest level of the healthcare provider system, Indian system, we will be able to achieve the target, which is not a very difficult target. So the targets which have been set to control and screen 75,000 of the population by 2025 is an achievable target, And this has been laid down based on certain evidences, and we can definitely, aim at improving and the outcome related to hypertension. So what could be the strategies? What could be the approach? We have to make sure that, yes, we have the infrastructure, we have the trained manpower, we have the available drugs, and we have the information system. Exactly that we said, e-Sanjeevani portal is there. We have the various the platforms on which the data for the hypertension at individual level can be put up. Then we need to know that what are the patients which have been put up on hypertensive treatment, and number of the patients to be followed up, number of the patients for which the blood pressure is under control. So there are various strategies which can target us in monitoring, in evaluating, in assessing the as the progress of 75/25 initiative under the government of India, the plan moves on. So these are the different approaches. We can scale it up, these activities, and regular facility based, not only facility based, there could be self-management and self-approach, self-behavioral practices also, which will target about the population or the public to come around to the facility and get their blood pressure examined. So I'll just talk about that, how this program has evolved and how we have included this, cancer, this hypertension control as a part of the national program for prevention of non-communicable diseases. And we started this program in around 100 districts to begin with in 2010. And now we have expanded it to almost every state and every district in the country and every union territory of the country. And this is really a good program if we are following it up, each and every goals, objectives, the manpower training, the availability of the drugs, resources, self-management, and monitoring and evaluation of the program also. So the main pillars of the program are that we have to do the screening, again, bigger component, larger group to be screened, early diagnosis, referral, and follow-up, and building the capacity of the providers and building the capacity of the medical and the paramedical health workers. This is the initiative which was launched by the ministry last year on this very day when I was attending a meeting with the Niti Aayog, the NHA, the Secretary Health and Family Welfare, where they had identified that 75 million of the population of the country would be put on care for the management of the hypertension and the diabetes by 2025. And we are just approaching 2025, around a 1 year, to go to achieve this target. And I'm sure this is a very, very appropriate and, good estimates that we can achieve this target at length. And simultaneously on the same day, we had declared that we will be training the medical health officers, the doctors of this country, and we have kept a minimum target of around 40,000 primary healthcare doctors to make them aware about that there need to be a standardized approach for the management. Standardized approach for the management of not only hypertension, but for other conditions through the services, through the packages, through the protocols, which we have developed with the Ministry of Health and Family Welfare, which is about the standard treatment workflows, which doesn't talk about only about non-communicable diseases, but other conditions also, because hypertension is a disease which is interlinked with many of the other diseases as well. As I said, I'll talk about, for some time about the India Hypertension Control Initiative. And this is a big platform, a very successful study. And the biggest component to make this study as a success was the role of the collaborators. As I had been saying in all of my talks, wherever I give my talk, that we cannot work alone. We cannot work in isolation. So this is one example where most of the collaborators have worked together, and I really clap hands for the Ministry of Health and Family Welfare, all the districts, all the states, all the NHM officials, all the drug providing companies that who had really come together and joined hands with Indian Council of Medical Research and World Health Organization and many other partner agencies to make that, yes, we can control hypertension. And in this, we were able to achieve 25% relative reduction in the blood pressure and we had covered around 4.5 crore people with hypertension, and they were brought under control. And this is one very successful, and it was not only done by only ICMR. So why we need the protocols, why the demand for having the standard protocol. So the main, the main starting point for having this India Hypertension Control Initiative was we need to have a standard approach. Many of the cases which are having hypertension are treated by various physicians, and I think we all have our own experiences to share with that a particular district, a particular state, a particular primary healthcare center, not only the facility, even the individual doctors sitting in one primary healthcare center will treat the case of hypertension in their own way. They have multiple ways to treat the patients. Some one drug therapy, two drugs therapy, multiple drug therapies, no drug therapy, only counseling. So there are some, specificity to be given to a local setting. So these guidelines, which were the Hindi guidelines, are very high voluminous. So the protocols are very, one pager low, and we are more specific information on the protocol than on the guidelines. Guidelines give a huge, large scope of multiple drugs. So keep converting those guidelines into the standard protocol was the first pillar in the India Hypertension Control Initiative, that yes, we have to specify the name of the drug, we have to specify the name of the prescription for the dose, and do's and don'ts, when to refer and who to refer, what are the high risk signs, and whether they can be used at a primary healthcare level or not, because the guidelines sometimes are better understood by the experts. So experts are experts. We need to make the protocols understandable by the primary care physician. Even below that also we need to have, so that was the aim that, this India Hypertension Control Initiative was that we need to have the standard protocols. So in that protocol, first we developed this standard treatment protocol, and then they went to the field, they went to the each district, they went to the each and identified facility, and they wanted to know that, yes, whether the medicines which have been the standard protocol prescribed medicines are available in that particular facility or not. So for that, there and made ensure wherever the supply of these medications and the logistics for measurement of the blood pressure were not available, it was made sure that there is uninterrupted supply of the drugs, there is continuous monitoring and follow of the patient, and then it was a team-based learning, it was a team-based care, it was a task sharing. So domestic visits were also performed by ASHA workers, by the ANMs, by other paramedical health officials, by the key informants, by the counselors, so that an integrated care is being done for the hypertension control. And not only we limited this India Hypertension Control Initiative just to that facility, we moved backward to inform the systems also that, yes, this is the impact of the interventions. These are the impact that when there is uninterrupted supply of the drugs, because the major fault among hypertension patients are that they are not getting the medications regularly. So they have to, stop the medication. And we all know that how much poor population is there in our country. So they definitely stop taking the medication, driving them to more poorer state, sometimes buying from their own pocket, which drives them to a poverty line, below poverty line, out of pocket expenditure. But other than that, if they do not buy the medication, if they don't get the medication supply from the healthcare facility, they are going to go to other private practitioners for which we do not have the standard protocol. They buy the drugs which is not for them. They buy the other category of the drugs. So lot many issues were there. So we try to streamline that. Yes, we have everything in place: human resources, drug supply, monitoring and evaluation, team-based learning, patient-centered care, mobile labs. So everything was put in place through the existing public healthcare system. There was no additional people who were given to manage this India Hypertension Control Initiative project. So one of the core strategy for IHC implementation: standard care, drug specific, dose specific. Establish steps to take blood. Like the today's theme is that measure the blood pressure accurately. Most of our healthcare workers are not able to measure the blood pressure accurately. They do not know where to keep the sphygmomanometer, how to measure it, how much to press it out, how to count, how to see the muffled sounds. So all those steps were also, even sometimes the doctors, even sometimes the junior residents are also not well versed with taking the accurate blood pressure, right? So the core strategy was again to have the normal protocols, reducing the clinical variability, that definitely resulted into cost-effective selection of the medications and the treatment approaches. So there were multiple options. It was not only that, okay, it was just, so rigid protocol. There were multiple options which were given to, follow this India Hypertension Control Initiative, like escalation of the first drug to maximum dose at step 2 before adding the second drug, or maybe addition of second drug at step 2. So the physicians were at liberal to choose any of the options. So, like for example, I can say that there were 3 drugs: amlodipine, telmisartan, and chlorthalidone. These are the 3 drugs which have been put up, and out of these survey and out of these experience, amlodipine happened to be the most preferred drug of first line of choice with the low risk of side effects, and this has become the standard protocol. And second drug comes with which is not preferred as first line drug, and same are the chlorthalidone, which is limited availability, need to monitor the potassium and sodium level. Physicians are prescribing these drugs, but having this India Hypertension Control Initiative, there was these things were definitely curtailed down and controlled. So there were challenges. Every protocol, every implementation research has a challenge. There is inadequate availability of the drugs, first line, second line, and the third line drug. Preference of doctors to give the combination of the drugs. We doctors are so much passionate about writing more number of drugs, number one. And sometimes the public also wants that one drug is not sufficient. They also want combination of drugs, lack of titration, frequent change of doctors. So these were the challenges, but these challenges were really overcome by giving this. So these were some of the learnings from India Hypertension Control Initiative. And based on that, further, we tried to standardize some of the protocols with developing the standard treatment workflow at ICMR level, which will be helping the physicians of this country, not only for management of the hypertension, but some of the other conditions, which is like cancer, breast cancer, lung cancer. And we have around 125 such standard treatment workflows, which are just one pager. All the drug dosages are mentioned into it. All the referral systems is mentioned into it. All the signs, symptoms are mentioned into one protocol. So it is not a situation that we need to only curtail the hypertension today. We have other morbidities also, which are, just mushrooming this country and taking a lot of the healthcare delivery systems time and challenges and out-of-pocket expenditures. We really need to learn from IHCI, develop such protocols. So, and this is like, you can say the last year, the right-hand image, you can say we were celebrating the World Hypertension Day last year on this day today, where we showed to the ministry, and we can see all the ministry officials there, where we released the standard treatment protocol, standard treatment workflow for the management of the type 2 and type 1 diabetes mellitus. And similarly, on the left-hand side, we have the standard treatment workflow for the management of the sickle cell disease and other hemophilic disorders. So what I want to say over here is that we really need to have standardized protocols if we really want to go for achieving the control. So these are the QR codes you can download. These are downloadable. Like in hypertension protocol, all standard treatment workflows are downloadable. Now coming to my third part of the presentation, I'll quickly go through that at Indian Council of Medical Research. Since I'm working here, it becomes my moral responsibility to tell the audience about that we are now able to undertake 4 categories of the research: descriptive research, the discovery research, the development research, and the delivery research, which is also called as the implementation research also. Now, what is implementation research over delivery research? Delivery is not related to the obstetrics and gynecology. It's an implementation. How are we able to make the programs more responsive? How we can deliver the outcome of the research to the health system comes into the delivery research, and it encompasses majority to the health system-based interventions, increasing access to the healthcare, implementing the national health programs like we are celebrating today, World Hypertension Day, and reducing inequity and improving the quality of the healthcare. So we really need to plan the implementation research. We can't do implementation research in just isolation. As I said earlier, collaboration, coordination, and communication is the pillar of any implementation research to begin with up. So we have to, do it together, strengthen our system. So this is a broad framework on which we carry out the implementation research, which is a consolidated framework. It itself is a self-explanatory. It has a 3 cores. It has an outer setting, it has an inner setting, then it has a, the characteristics. So if you see the outer setting, which is overall the policy environment, who are the implementers? So they are the outer setting. They only guide, they only see, they oversee that what is happening at a policy level, what the research outcomes are there, what are the commitments, are they able to create the suitable environment for upscaling of the policy decisions, will they use the data in policy decision? Now we have the inner setting. What is this inner setting doing? Inner setting is the public healthcare system. Inner setting is our national health mission. Inner setting is at how much harmonized we are with our each other. Do we talk our national health authority together? Do we talk among each other about when we are drafting the policy for the hypertension, and along with the child health program? Is the juvenile hypertension not a problem? Is the adolescent hypertension not a problem? Is the stress among mental health researcher or mental health program is not a problem for the hypertension control man? So this is about that we need to have the harmonization about the departments. Then what are the data? What are the access to the knowledge? What are the different mechanism, inventory mechanism? Where are the resources? Do we have the trained manpower? So all those thought process will go to the inner core, which will there to have at a peripheral level or at a inner level, who are really the force behind achieving the policy outcomes. Then we have the interventions. What like intervention? Like I give an example of INAP. This neonatal mortality program. We have to prioritize whether there is an intervention which is working, it has a data, will the NHM will be able to upscale this intervention, and with the policy level, whether the suitable environment will be created or not. So like that, this is the consolidated framework for having the implementation research. And of course, I have not put up the international players, which definitely have a role, but not a major role, because Indian problems are the Indian problems. We need to sort out the malnutrition at our level. Maybe we need to sort out the problems like tuberculosis. We need to sort out the problem of environmental. We need to sort out the problem like, infectious disease, which is an Indian problem. So this is the overall design for the implementation research. It starts from zero model. We start with a model which is called as a model zero. For example, we say that, okay, currently we have this many drugs, this many manpower, these are the strategies, whether they are working to control hypertension or not. That will be called as a model zero. And then we do a formative research over here, and we try to modify our deliverable model, and then it will be called as a model one adopted. So with whatever model the interventions are going to work about after the formative research, with the support from the evaluators, with the support from the facilitators, with the support from the implementer researcher, we will modify the M0 model. And that model, which is called as an iterative model, we have optimized that model in a way that is equitable, that is highly covered, and say that, okay, now this model is okay. For example, we need to achieve the neonatal mortality. Why are we not able to achieve neonatal mortality? And why are we not able to achieve our control of hypertension? So there are certain factors. To understand that factor, we need to have the formative research.
You can take some water, Dr. Ashu.
Pardon?
Take some water.
Okay, give me a break.
Just relax for two seconds. Yeah. Okay.
Yeah. So this is but I was trying to explain the implementation research, the overall model. On the left-hand side, we start with model zero. We do the formative research. We plan our interventions, whether those interventions will be working in particular scenario. For example, that intervention may work in a UT like Chandigarh and may not work in the state of Kozhikode. That intervention needs to be modified in context of availability of the resources, availability of the manpower, availability of the political willingness, and there are facilitators. They may guide the government that, okay, you need to plan like that. Sometimes there are various, this district health officers or the state level program officers, they are not aware of that what is happening at the ground level. So here the implementer facilitators, they can go to the state and modify and suggest them to make certain changes into the implementation phase to come up a model which is called as an iterative and optimized model. So this goes on till we, achieve our desired outcomes as an base of the implementation research. Even if we see that the WHO health system, they have the 6 system building blocks. They have to strengthen the service delivery, health workforce, health information system, access to essential medicines, financing, leadership, and the governance. And most important in the implementation research is the community engagement and covering the equitable access to the larger resources to the health systems, ensuring the quality, ensuring the safety, and making the system accessible, responsive, conducive, and affordable. So these are the 6 building blocks of the healthcare system framework for undertaking the implementation research. And of course, when everything is in place, we don't say that the things will come in place soon, but it will take some time. But on the right hand side, we have the desired outcomes. And of course,
Dr.
there are
Ashu, you have to sum up fast. You have to
I'm just summing
conclude.
up because
Yeah.
I also have to go to another meeting at
Thank you so much. But it's a very nice presentation, but we request you to
So,
please.
so I will just sum up here that these are some of the approaches. I just flicker it very soon. Like we have some of the interventions like self-monitoring, the tailored feedback, the telehealth, right? These are some of the interventions which we can think about it, how to do a case manager, how to have the remote consultation, how to use the tool, how to have, network interface. So these are some of the, strategies through which we can adopt it. And I think my list of the slides are about the implementation research design part. So I will not go much in detail about the design part because that's not the scenario, but I will just like to stop over here and thank you so much. But I think this is a very, very important and session for all of us to, say that right theme is there and right strategies are there, and hopefully we will be able to achieve it as soon as we can do that. So thank you so much. Thank you, Dr. Venkatesh and Dr. G.K. Pal and other dignitaries.
Thank you so much, ma'am. Thank you so much for such an enlightening session. And thank you for joining in spite of your busy schedule today. Now we will proceed with our next speaker. Now I would like to welcome Dr. Jugal Kishore sir. Sir is a renowned public health expert. Sir is director and former head of Department of Community Medicine at Vardhaman Mahavir Medical College. He has authored over 40 books and more than 350 research papers. Dr. Kishore has played a key role in establishing Community Medicine Department and Center for Occupational Health. His extensive involvement in national health programs and his advocacy for public health education have significantly contributed to shaping health policies and practices across India. We are delighted to have you, sir. Over to you.
Thank you. Thank you very much, Venkatesh. Namaste, ma'am.
Thank you. Thank you.
Yeah. Hello, Hari Shankar. Uh, actually, another CME on adult vaccination is going on. So, I'll take less time because my job is done by Dr. Ashu. She has already taken up most of the issues which has to be, covered under the national program. So, but when we talk about hypertension is a part of the, cardiovascular disease. And we already know the cardiovascular disease has come up and it is a lifestyle disorder. We know what are the, factors which are leading to lifestyle disorder. Usually it is diet or the way we are living, particularly the environment is very important. We already know that epidemiological transition is going on and it will go further, but we are already witnessing what the problem in Western world has witnessed, which is mainly of the ischemic heart disease or cardiovascular disease or COPD, which has emerged from low rank to higher rank now. And some of the issues of, you know, the the problem which were not there at all has gone up in this period. So this burden is already high, and the loss of uh, economy is also very high when we talk about unhealthy lifestyle and faulty diet, which is directly linked with our hypertension. So huge amount of the our economy is lost due to ill health, due to cardiovascular disease and mainly hypertension. It is more than 140 systolic and diastolics, one more than 90 mmHg, uh, with and without. Like it can be single, maybe systolic or diastolic, but that is what. The problem is that a very big number of the population is suffering from hypertension. And uh, those all statistic is continuously monitored, and we can see in different national family health survey and individual survey carried out in various part of the country, showing that upward trend, and hypertension is still going up. Uh, some of the true facts which are recently by the Lancet publication showed that majority of the people, when they first diagnosed, they have actually never investigated, and in the end they come with the complications. At that time they found that they have hypertension. So these are the things which are preventable. We can have a healthy life, but just because of your ignorance and uh, not screening the hypertension, which is so simple to take, leading to such problem. So these facts are already known to most of our fraternity of the public health and otherwise also, that these can be managed, they can be prevented, managed, and we can definitely rehabilitate the person when they are suffering. So our focus should be on risk factors, uh, and then early diagnosis and treatment to control majority of the issues, whether it is a stroke or kidney disease or eye problem complications. So for a long time, we were expecting that the national program will come out, and in the end, it has come. Although the indication was already there that non-communicable disease is emerging, but in 12 5 plan, I think 11th 5 plan, some initiative was done, and then in 12th we have a full-fledged program. So this national program for prevention and control of, previously it was a cardiovascular, stroke and cancers. Cancer was added later on, but mainly it was focusing on. So it was started as pilot in 100 district in 21 states, and then by 2017, the all country, all the states of the country has to be covered by this. It is already said that we have the strategy where the health promotion of lifestyle need to be through behavior change should be done. Then another strategy is the opportunistic screening, which is in the form of the health camp. Uh, whoever is coming more than 30 years should be screened. Then their diagnosis, treatment, management, all these things are also part of the strategy. Another one is that the manpower has to be trained uh, so that they can screen and treat. And who can be trained? So for various activities, the various health workers, whether it is the ASHA workers or a medical officer or maybe the A&M, all need some kind of training. So the development of training is also one of the strategy. And then, when they reach to, health center, through that, how they can be, referred to a higher center, whether higher center is able to manage all these things. So the program management is required. So these are all strategies. Now, under these strategies, the various interventions has been launched. And if you see that we have the more than 10 type of, activities which need to be done under this program, which are also look into the hypertension. So public awareness through multiple media, the counseling for healthy lifestyles in different areas, particularly the schools and different settings. Then screening of persons when they are coming for some uh, mela, or maybe some camps are being organized. Then the management of the case through our centers, like we have the NCD clinic at the primary health center. We have also started in our 3 centers. Also at the district level and higher level, a special clinic has to be, the infrastructure should be done where the equipment are available, where they can be trained and also provide the services. And then management of the whole thing for the monitoring and management. So under the program, we have the national NCD shell, under which uh, the one program officer, 4 assistant, and one epidemiologist, financial come logistic consultant, 3 consultants. All these things have been conceptualized and made provision for this program. State level also, the manpower was given, and the district level also given. So when we see that, different these, structure which are proposed in the program, has to be placed where various activity can be done for different strategy which we have discussed. And these all things are part of the, whether it is a primary health center or community health center, even reach to that health and wellness center, which is also crucial part. So the state level, district level, and then we have, these all sub-center, what need to be done. The A&M or male health worker has to, do this screening, opportunistic screening, and they have to, conduct the counseling sessions and refer to CHC if they found positive. Even some kind of incentive is also proposed in the program, like if they are maintaining the data, collecting the data and putting under Aishman Bharat, then per form, per person or per family, and how much money should be given. And then, also there is a form of the risk factors in which you can identify the person having hypertension or diabetes. Then 10 rupees is given per form, per person, one-time incentive, and then follow-up. So per person per year, twice, a year, 50 per case, 50 rupees per case has been provided. So these are the incentive to these, ASHA workers. Now, under the lifestyle, initiative, the government has already started, and some of the program were organized for the parliamentarian. Then website is also launched. The Fit India movement or initiative has been done. The Poshan Abhiyan is there. So beside the Ayushman Bharat, we have various other activity. Fit India was, again, a very interesting and important initiative by the present government, which increased the, awareness. Some of the new initiative under the programs are like, including not only just the previous, diseases, but also CKD or COPD. They were also become the part of the, program. Then for early detection, the population-based screening, by the frontline workers, and the money was given, which I have already said. Integration of Ayush with the, non-communicable disease, because they can easily identify, uh, these problems, and they can put on drugs. And there are drugs which are also available in there's discipline, also the yoga which is advocated by our modern system, and also the Ayush people. So both can manage majority of the lifestyle problems. Then pilot interventions for the prevention and control of rheumatic fevers and rheumatic heart disease, and integration of, we have the TB program now. The TB elimination program is also there, but linked with the NCD, because the diabetes is also part of it. So you can detect a lot of the NCD problems through this program also. So these are all new initiative. But when we say critical comments, so I have found out in the literature where the evaluation has been done, although regular evaluation and monitoring is not being done for this program, but whatever is there, we can assess and we can find out. But few publications showing, that how much achievement we have. So already 696 district have the NCD cell, 707 district NCD clinic has been established, 193 district cardiac care unit has been established, 268 district care daycare center for cancer patients and NCD clinic was established at CHC. Almost 719, 7.19 lakhs ASHA workers and 2 lakhs 25 lakhs ANM or multi-purpose workers, and community health officer 80,000 community health officer, and 90 uh, around 30,000 staff nurse, 30,000 the medical officer has been trained in national program. In spite of all this, what has been found out that uh, you will not find activities or say the success in all the areas which is expected, but whatever is possible we can increase by identifying what are the gaps. So at the community level, what is has been found that actually we when we say evaluation of the program, we don't have the target population well defined, and because of that you are not able to see the impact in that group. So that's a big problem with this program, that you are doing the screening, and screening, if it is done at the you know uh, at the mela level or maybe some kind of a camp level, so you don't know what kind of problem exists in the population. It cannot be generalized to the population. That is why this unknown target population is a big problem at the community level, to find out whether our community is suffering and how much improvement we have done in identification and putting on treatment. Another is the knowledge gap is still there, not only in our community, where the risk and their preventability is poor, but even our health workers, or the even the health staff is also poor in identifying what problems are there, what kind of integration has been suggested by the government, and what can be done, whether this program has to be monitored in a proper manner. These all gaps has been identified at the community level. But when we say at the healthcare setting level, then there's again, the in community medicine, we have learned the referral is a big problem. And in this program also, we are finding, they have been identified, but they should be referred to higher center if it is not controlled, or maybe I think some problem is there, uh, but it is not found, because referral should not be just sending it. It should be having some mechanism where the person can be handled when he is going to a higher center. So it's true for all our public health program where we are missing the link. That is why the referral mechanism should be considered as one of the biggest gap in this. Even one of the pan India study has been found out that you know 43% of the patient had their BP checked at the time of diagnosis. So very less are diagnosed, less are checking their BP regularly, or you can say during the examination. There is a lack of timely supply of vaccine, which has been identified by Ashu, presentation also. That is again a big problem, and they are trying how we can have that continuous supply of the drugs. And it has been found in many of the centers, even in our center, sometimes basic drugs like the amlodipine is not available for almost 1 month. So, breaking of such, availability of the drugs for regular control is not possible. And availability of the, diagnostic kits, trained providers, medical officer, in all the things are again a problem. Another issue is that, still the people are believing in private practitioners, and the private practitioners are controlled or maybe managed by, pharmaceutical information. So they start with the drugs which is actually not advised by the protocol or maybe standard guidelines. So they are already receiving the drugs which are actually not a part of the protocol. So we have a mismanagement of the, hypertension, leading to lot of, compliance problem and lot of monitoring problem. The another one is the gap at the policy and research level. Again, the, Ashu presentation also indicate that we require implementation research. So in that also, although we are focusing on the therapeutic and curative, but we require, a, a primary level of research where the counseling, lifestyle modification, behavior change communication, implementation leading to some change in the community, such kind of research is required in India. Although in other countries it's happening, but, in our conditions are different, the population knowledge is different, the culture value system are different. And unfortunately, we don't have the trained counselors. So we, whatever available, the resource we have, human resources we have, we have to use them and see that whether such kind of intervention is useful. We have to see that these people already trained, um, as a BSc level or master level, they should be made available, or say the vacancies should be created for them, which can become the part of the program, because we really require the counselors, the statisticians, dietitians, which can combinedly, uh, making the change in the, system, particularly the hypertension. So with these words, I think I want to say this, that all these things you can find in my National Health Programs of India, where the critical comments of the national program is given. So thank you very much. I just want to say I have taken a little more time, but sorry for this. I'm sorry.
Thank you so much, sir. That was very useful insights regarding the update of NP and CD, and you also provided the critical appraisal of this NP and CD program. Really nice to hear you, sir. And in spite of having your CME on adult vaccination, you agreed to be with us. I'm very thankful, sir. Thank you so much, sir, for being with us.
For Venkatesh, always ready.
Thank you,
One
sir.
of my, ma'am, one of my favorite.
Yes, yes,
Doing
very,
wonderful.
very true.
JJ. So I'll leave, ma'am. Thank you.
Thank you, sir. Thank you. So with this, we will proceed to the next speaker. Dr. Ravinder sir will join afterwards, ma'am. So I will proceed with our next speaker, Dr. Pradeep Agrawal sir. Sir is going to speak about some of the initiative which he is doing at AIIMS Rishikesh. And sir is additional professor at AIIMS Rishikesh and specializing in community and family medicine. A alumnus of Himalaya Institute of Medical Science. He have extensive experience in public health, evidence by his leadership over 50 research projects and authored more than 85 published articles. Sir is renowned for his contribution to epidemiology and has received numerous national and international fellowships and awards. He is actively involved in advising on FOPL to enhance public health, nutrition awareness and policy. We are nice to have you, sir. Over to you.
Thank you, Dr. Venkatesh. Thank you. I hope my slides are visible and I'm audible.
Yes, you are visible and you are audible also. Maybe you can try moving your slide also. That will be better. ठीक है. That's okay. Good.
Thank you, ma'am. Respected madam and respected my dear colleagues. This presentation, मतलब इसकी अगर जननी कोई है तो वो मैम है, मैम सुनीला गर्ग. We started with the whole of the idea of front of package labeling and how we at AIMS Rishikesh have linked it to the non-communicable disease. That is what I'm going to take up over here. The initiatives taken by the AIMS, and ma'am is one of the guiding force for this particular whole of the idea of healthy food for all. AIMS Rishikesh is also a part of the advocacy program from the Global Health Advocacy Incubator. And currently we are undergoing the second phase of the project, that is the linking of the food habits with the non-communicable disease, especially the hypertension and diabetes mellitus. I'll go into the brief achievements first of all. One of the key objectives of this particular project is prioritization of hypertension as a public health priority. What we have seen, our previous speakers have already told from the ICMR, from Dr. Jugal Kishore, things are available, documents are there, but how it is being implemented at the level of the patient. So we need to collect and document the repository of the patient stories and the voices. We need to have the voices and the insight into the systematic barriers, social norms, behavioral attitudes, impacting the quality of hypertension treatment. So that is one of the main objective why we have started this whole of the project regarding hypertension. We know we conduct lot many surveys, we collect data, everything we do, but are we really interacting with the patients, the end user, the entire bread earner of the family being an hypertensive? So another way to get into the insight of the program is we should have the patient voices and patient stories to understand the real challenges at the community level. There have been a change in the name of the program. Initially, non-communicable disease for chronic diseases, inclusion of another disease, now NP-NCD. But who is the end user? End user is the community. If you see with these photographs, majority of them are approaching 60s, might be above 60s. So it becomes the age-related problem, hypertension. Another challenge is who is going to support the financial issues? Who is going to take care of their locomotor things? So this active was focused on the treatment adherence and the difficulties faced by the people living with the hypertension. And going back to the health center is another important challenge. Getting the medications, regular compliance. So those were the key challenges which we were able to understand, and that have created a buzz in the social media during the World Stroke Day also, because hypertension outcome is one of the drastic outcome is the hypertension. In continuation to these patient stories, what we have heard in the two renowned presentations, the government of India is having a program in a place, but are we prepared? So in that scenario only, the Ministry of Health and Family Welfare have recently launched an ambitious initiative of 75 by 25. Ma'am have already written an editorial on it that have been published in a PubMed journal. And it says screening and placing of 75 million people with hypertension or diabetes on standard care by 2025. Now the big question is, are we prepared? Are our health center prepared for just a simple screening or not? So that is a situational analysis we have started recently to provide an insight into the existing infrastructure of NP-NCD for screening of hypertension and diabetes. I'll be going through just a small slides regarding this. And so whole of the Pan India is being divided into the zones, and every zone, 6 zones, that is north, west, south, central, east, and northeast zone. And from the each zone, we are going to select 2 states, 2 PSCs, 2 CHCs, and 1 district hospital. This is going to give us a glimpse of the existing Government of India's ambitious program of 75 by 25. Is the infrastructure ready? Are we having a manpower? Are the drugs being provided over there? Is there a compliance? Is there a NCD register? Because what we have seen in the past slide is out of the 600 districts, how many districts is having NCD cell? But are these NCD cell functioning? Is a simple instrument like BP instrument is available? Is it functional? So those are the challenges we need to address through AIMS Rishikesh this time. All of the data is going to be collected electronically using the EpiCollect, and it is based on the IPHS standards. The primary focus will be the infrastructure and the manpower, the training issues. The expected outcome. By the end of the studies, we expect to obtain the following information, that is the availability of the minimal infrastructure at various levels of healthcare facilities, the percentage of the eligible population aged 30 years and above diagnosed with hypertension and diabetes. Do they have a register in which they are entering day-to-day screening? Percentage of eligible population aged 30 years and above to put on standard care, that is lifestyle modification and treatment for hypertension and diabetes, and the training needed. That is the strength, weakness, opportunity and challenges analysis for implementation of 75/25 Government of India's ambitious mission in India. So that is the brief I just want to share regarding the ongoing activities from the AIIMS Rishikesh. Back to Dr. Venkatesh. Thank you.
Thank you so much, sir. You are really
And
wonderful.
just to note, everyone is invited through Dr. Venkatesh or Sunila ma'am to join us. It's a software we have already designed, all those, but these should not be a medical college linked health facilities. Because if you are in a medical college, you are going to get all the things. We need the data from a non-medical college attached health institution to get the real picture so that we can support Government of India's initiative. Thank you, Dr. Venkatesh.
Thank you so much, sir. Your message is clear and crisp. And thank you for your presentation. And you really raised some valid questions, and all the very best for your project. So with this, with permission from chair, I would like to call Dr. Ravinder, sir. Sir is waiting since a long time. Sir is focuses on mental health. Sir is a senior scientist at ICMR. Sir works in the area of mental health, disability rehabilitation, and assistive technology. He has over 2 decades of research experience and collaborates closely with WHO and other organizations to integrate assistive technology into Indian health system. Additionally, sir, pioneering work has been instrumental in enhancing accessibility and support for individuals with disability, thereby fostering inclusive healthcare practices across the country. Nice to have you, sir. Over to you.
Thank you. Thank you, Dr. Venkatesh, Dr. G.K. Pal, Dr. Joshi, Dr. Sunila, Dr. Jugal Kishore, and my previous speakers, Dr. Pradeep and Dr. Ashu. Thank you for inviting me to this webinar. So, can you stop screen sharing? Yes. Okay. Now you go ahead. Up karo. हाँ. नहीं, last one, last. So, as Dr. Venkateshwar, you have so, and
I think open up is, yeah, now it has come. Now it
yes.
has come.
So I was wondering that how do we justify the assistive technology for hypertension? But when I actually looked into this area, and I found out that it plays a very, very major role. Even I am attending a parallel meeting with the Ministry of Social Justice right now, where there are 3 solutions for diabetic foot, and another assistive technology which they want to support. Now, let us go to the next slide, please. So assistive technology empowers person with functional impairments. It's not only the disability, but any condition which actually impairs our functions. And as per WHO, the health role of the health is to restore our function or provide the treatment which integrate us back to our society, to work or to education, and sports, recreation, and leisure activities. So any assistive product is defined as any product that improves the life of individual who may otherwise may not be able to compete complete the task without specialized equipment, and which can also improve accessibility and quality of life. So assistive product is any aid, device, equipment, software which helps in enhancing our body function, mimic or replace. Next, please. So we know that assistive technologies, they enhances health, they improve quality of life, they actually increases the independence of person who is using it, and they also help us in greater accessibility to reach the places where other person would not be able to go, those who have the functional impairments. Next. So there are various conditions in the patients with hypertension, like TIA, stroke, dementia, mild cognitive impairment, which actually would put a person in a condition where assistive technology would be required. Next. So they also damage the eye for actually hypertension impact the vision also through retinopathy, choroidopathy, and loss of vision or optic neuropathy. Next. So these are the complication of hypertension. It's not extensive, but it's very small number of condition which I have taken, which actually will put a person in a condition where assistive technologies would be required. Next, please. So they help us in prevention of hypertension, and they help in various technology. They help in prevention, diagnostic or therapeutic purpose, as well as later on rehabilitation and assistive care. So healthcare continuum currently now as WHO defines is starting with prevention, promotion, management, rehabilitation, assistive care where assistive technologies are used, and palliative care. So in the case of hypertension, the blood pressure monitors and smartphone apps are very useful in these patients. Next, please. And we have a wearable devices and health tracking devices. Now, wearable devices are very important in such cases where constant monitoring is required. So here, there are various now devices which are helping people to monitor their conditions on hourly basis or minute to minute, and make a beep or alert them so that they take a either medicine or consult a doctor. So there are AI powered wearable devices and mobile apps which continuously monitor patients' health metrics, and AI powered wearable and mobile apps facilitate remote patient monitoring. So these assistive technology not only are there with the patient, but they also help the physicians to track the patient's health remotely. So if there is any dangerous sign or red flag, so the physicians can talk to the patient and advise him appropriate interventions. Next, please. So there are smart home devices also, where these devices, they help patient maintain the relaxation or meditation. They reduce stress. They have so immediately when a person enter a home with smart device, these device they actually feel the condition of the patient, and then will produce this kind of environment which would be beneficial for their health conditions, especially for hypertension, so that they remain calmed and they become relaxed. Next. And remote monitoring actually enhances the precision, reduces the error, and these are the all remote monitoring apps which are there now. We have telehealth systems. Next, please. Which assist in the patients for prediction, for efficiency, and for the suitability. So patients, they don't need to visit the physician in person. So remotely we are able to control all of them, their condition, and provide them appropriate interventions. Next, please. So patient engagement and education is again another benefit of assistive technology. So we can have a personalized health advice. We can have medication reminders when to take the medicine. We can have educational resources which help the patient to constantly update their knowledge, and also help in the doctor appointment, so that they don't have to wait there, go there and immediately see the doctor. There are chatbots also, and there are communities also which are helping these patients to seek help. So these are the domains of health as per WHO. So functionality, morbidity, and mortality. So I don't want to go into detail of this one. And hypertension impacts physical, physiological, and sensory functioning of the body. So all of them, they would require some sort of assistive. So this is particularly in case of hypertension, which is not controlled properly. But if we control, we can, during the control also, the various assistive technology they do have. Next, please. So thank you very much. I think the more information we can talk when we have enough time. Thank you very much, Dr. Venkatesh.
Thank you, sir. Thank you so much. I think first time I'm listening assistive technology in relation to hypertension. It is the first time, sir, and
Chronic diseases are very important.
yes, yes. Your insights have truly inspired us to think deeper about the possibilities, sir. Thank you so much for joining with us. Now, I request Dr. Sunlagar ma'am to kindly comment on the speakers and the session which we had.
Thank you, Dr. Venkatesh. It was indeed a very, very wonderful webinar, beginning with Dr. Ashu, where we talked about, she really talked about the theme of the day, where she said that measure your blood pressure accurately, control it, and, you will live longer. That is important. But what was very important was she focused on the systems approach. And then another important is she divided her talk into three parts. First was related to hypertension. Second was related to India Hypertension Initiative, and the third part was the implementation research. And she built her talk very nicely by strengthening, overall. That means, how hypertension is a problem. Another thing is that how do we look at the risk factors? Then how do we manage our systems? Because we all know that it is only 50% of the people who are reaching the system, and out of which only 50% of them, they adhere to the treatment. So that is important part which was managed. Another important was, looking into the program by Dr. Jugal Kishore, and he really, outlined the risk factors of hypertension, about the importance of the day. And then also he also stressed upon, basically the systems part. And also, he looked at, the adherence to the treatment, and all those parts were mentioned by them. Another thing was that I looked at that, hypertension cannot be looked in isolation. We need to look at the other non-communicable diseases as well. Now, another part was, which we need to look at, that basically, unless the whole subject is, kind of complemented by research, particularly now is not the era of, we are talking about discover, we are talking about develop, we are talking about deliver. And so that is where we need to focus on the third D, that is the deliverable part, and that is the implementation part, which is very, very important. We need to look into the newer drugs. We need to look into the, kind of adherence part also, that is important. And also Dr. Jugal mentioned into that how, from the top level, we go down to the, consumer level, so that, ultimately we need to look at the habits of the individuals. That is important part. And then the third part, where Dr. Pradeep Agarwal mentioned, under the aegis of healthy food for all, this was initiated by AIMS Rishikesh, and I know that under which various webinars were conducted, and we debated in depth about front of package labeling. Because when we talk of obesity, when we talk of, other, comorbidities, hypertension comes into, it's an overarching thing. So that is where it is very important. And he also looked at, kind of they have completed phase 1, from May 2021 to May 2023. And then, ultimately now they are linking the food habits also. And somewhere Dr. Ashu also mentioned about the case studies about adherence and all that, but this is much more in depth where we look into the food habits of the individual, right from, the child to the adolescent to the, adult and to the elderly. That is where it plays a very important part of it. So, we need to look at and these stories are going to be very, very useful. And I'm requesting Dr. Pradeep that, it will be very useful if these stories are shared not only at, at national level and with all the academias and all, but we share with WHO as well. So that will make, important case studies for our students as well. Now, coming to the role of assistive technology, like Dr. Venkatesh, you said you heard for the first time. I know that these assistive technologies are very unique. Now, what will happen, not only we need for hypertension, where he mentioned, when you program the assistive device, according to, the problem, whatever is there, it will act. Suppose you require soft music, you require stress reduction and all, that will be very, very important part. Again, their role in transient ischemic attack, stroke and all, dementia and all is well known. So we need to look at that part also. The best part is that in order to improve the adherence, we do not need doctor at our doorstep. So that was very important thing which he mentioned. So remote monitoring is also possible. So overall, I'll say integrating research, policy, innovation in hypertension management was a unique webinar. And I will be very, happy. And I'm rather happy to mention that, this is there on the YouTube. All our faculty members, PGs and all make this news viral so that everybody can view this, Dr. Venkatesh, so that, all our partners will have the benefit of this wonderful webinar. And definitely we must bring out a letter to editor and a publication out of it. And thank you to all the speakers who have been wonderful speakers. And thank you to Dr. Paul, that our director of AIMS Gorakhpur, for, holding this under the aegis of AIMS Gorakhpur, because the title itself is so very unique. That means we do not stop only at hypertension. We need to go deep and deep into the research part, particularly the implementation side. We need to rely on newer innovations, which will ultimately have impact on the policy. And then these all will play an important role in hypertension management. Like, now we are looking at the assistive devices also. If our environment is good, if we are having a soothing music and all, that plays a very, very important role. And also smartphones. And that is where it is important that we need to look at the newer apps as well. So all presenters were extremely very good. So my thanks once again to all the faculty, Dr. Joshi, and I know the department is very active and very, very nicely moderated seminar, Dr. Venkatesh. And my heartiest congratulations to Director AIMS Gorakhpur and holding a dual charge at AIMS Patna. So my best wishes to all of you. Thank you so much.
Thank you, ma'am. Thank you so much. We plan to document the proceedings of this event in a paper, like you said. We always value and look forward to hear your insights. Thank you for your continued guidance, ma'am, and your unwavering support throughout the planning and designing of this event. Your guidance has been invaluable. Much like guiding light or a mother, we are deeply grateful for your mentorship and leadership, ma'am. Thank you so much. With this, I invite Dr. Anand Mohan Dixit, sir. Sir is additional professor in our department to deliver a vote of thanks.
Thank you, Venkatesh. As we conclude today's enlightening webinar on integrated research, policy, and innovation in hypertension management, it is my privilege to extend the vote of thanks to everyone who contributed to the success of these events. Firstly, I would like to express my deepest gratitude to our chief guest, Professor G.K. Pal, sir. Sir, your gracious presence and invaluable insights encourage us to conduct this webinar. I am especially thankful to our esteemed chair, Dr. Sunila Garg, ma'am. Ma'am, your leadership and expertise in public health have significantly shaped the direction and tone of today's session. Ma'am, your profound contribution to the field and your ability to facilitate important discussion have been pivotal in making the webinar as a success. Thank you, ma'am. Our thank also goes to Dr. Harisankar Joshi, sir, for providing an inspiring welcome speech and setting the stage for today's thoughtful exchange. Along with that, a warm thankful to all distinguished speakers, Dr. Asu Grover, Dr. Jugal Kishore, Dr. Pradeep Agrawal, Dr. Ravinder Singh. Each of you has brought invaluable perspective and expertise, greatly enhancing our understanding in hypertension management with multiple angles. Accordingly, I want to thank you all participants for their active engagement and insight. Your involvement is essential for the success of such knowledge sharing platform. Once again, thank you all of you for joining us. Thank you, Venkatesh, for giving me as opportunities. And I would hope that department will again welcome you on such platform. Thank you to all of you.
Thank you, ma'am. Thank you, ma'am. Thank you, sir.
Thank you. Thank you, everyone.
Thank you.
madam. Thank you.
Thank you.
And-
Thank you, Pradeep. It was really interesting, and I feel that I'm looking forward to these case studies.
Ma'am,
And
yeah,
I will
ma'am, in
share
fact,
one.
yesterday only we got the approval. So soon we will be calling up the meetings.
Yes, because I've just completed one, on fitting of hearing aids, by the help of frontline workers. And we have recorded 26 such case studies that how their life has changed overnight, kind of. So that's how, so these are very interesting, and they can become case studies for our students as well. So it will be really good. Thank you so much. Thank you.
Thank you.
Thank you.
Thank you.